Any joint that has a fluid-filled capsule surrounding the articulating surfaces, via bones or bone to cartilage, whatever it may be, is considered a synovial joint, a fluid-filled capsule surrounding the articulating surfaces. All synovial joints are always going to be classified as diarthrotic joints or freely movable joints. As I mentioned previously, the range and degree of motion might be different considering which joint you're talking about, but all will always be considered diarthrotic joints. Most synovial joints in your bodies, so these are the most abundant joint in the body, and most of them are simple. They just have two articulating surfaces. Think about like the knuckles in your fingers, for example. But some joints in the body are compound, and they have more than two articulating surfaces. The elbow, we've got a humerus meeting both a radius and the ulna. Your knee has a femur that meets with the tibia primarily, but it also includes the fibula and the patella in that joint. So we do have some examples of compound joints where there are more than two articulating surfaces. The example given here is a simple synovial joint. This could be a synovial joint between two phalanges in your digits, or maybe a phalange and a metacarpal at your knuckles between your hand and your fingers. But two bones, so a simple joint. And you'll notice here that this has been sliced open in a longitudinal plane, and we're able to see the outline of the joint capsule out here, and then this hollow space on the inside of this cavity. When you look inside of a fluid-filled synovial cavity, what you'll see is that the bony surfaces are always going to be covered by a cushion of hyaline cartilage. This hyaline cartilage, remember, has lots of collagen plus the chondroitin sulfate ground substance. This is the articular cartilage, and its main job is to cushion the bony surfaces. Remember that cartilage is both avascular and not innervated. So it's the perfect tissue type to cushion the much more sensitive bone, which is both vascular and innervated here in our bodies at every movable joint here. The cartilage also is able to absorb compressive forces that may be experienced during any sort of movement at this diarthrotic joint. The cavity itself is going to hold a small space, and that small space holds fluid. The fluid is called synovial fluid. It's a very slippery fluid, and the whole point of this synovial cavity is to prevent the bones from touching one another. In fact, the hyaline cartilage should not even really touch each other in most of these synovial joints. The hyaline cartilage, the articular cartilage surrounding the coverings of each bone, should simply glide on the synovial fluid, reducing friction that might be otherwise caused at these diarthrotic, freely movable joints. The articular capsule, so what's making the cavity is this articular capsule here, and it has two layers. The outer layer is known as the fibrous layer of the capsule. This is the strong collagen-rich covering of the capsule, and if you look, you'll see that it is continuous with the periosteum that covers each of these bones. This anchors the fibrous capsule to each bone, and it prevents it from shifting. So the collagen fibers of the fibrous capsule will become the collagen fibers in the periosteum. Again, making this a nice continuous covering of each of these joint surfaces. Inside of the fibrous capsule, so deep to it, it is this purple layer. It's known as the synovial membrane. The synovial membrane is a membrane. It's made of simple squamous epithelial tissue lining the inside, so facing the lumen, and that's supported by a thin layer of areolar connective tissue, which would be closer to the fibrous capsule side. Remember that areolar connective tissue has a lot of ground substance space. It's a loose connective tissue proper. The ground substance fluid of the areolar connective tissue percolates through the simple squamous epithelial tissue of this membrane. So it percolates through in this direction, and becomes synovial fluid. The job of this purple synovial membrane is to make the synovial fluid that's going to fill the inside of the capsule space. That is the job of the synovial membrane. Makes that synovial fluid. That synovial fluid is really, its primary job is to reduce friction. So where does that fluid come from? Well, it turns out that all fluids in your body are filtrates of blood. The fluid in your blood is blood plasma. Blood plasma is circulating all around the surface of this joint, and as blood plasma passes through any capillary bed, some of that plasma fluid leaks out and becomes tissue fluid, also known as ground substance. The ground substance in the areolar connective tissue in our synovial membrane percolates through the simple squamous epithelial cells and becomes synovial fluid on the inside of the cavity space. So ultimately, that fluid is a derivative of the fluid in our blood. In fact, all fluids in your body are ultimately derived from circulating blood fluid, circulating blood plasma that leaked out somewhere along the way. This synovial fluid is no longer blood plasma. It's much slipperier, more slippery. It's very oily. It has the consistency of like raw egg white. So it's this thick, oily, slippery liquid that again helps these two articulating surfaces to glide adjacent to one another, really glide on the fluid and not touch one another. It also helps to nourish the cartilage. So the fluid of the synovial fluid can actually squeeze in and squeeze out of the hyaline cartilage, helping to nourish those chondrocytes and keep them alive. That's one of the reasons why even a patient that is paralyzed or bedridden is going to experience exercises, right? People will help assist with movement of all of the joints of the body. And the whole point of doing that is to actually keep the cartilage cells alive. These chondrocytes in the hyaline cartilage need to be able to exchange materials, get nutrients in, get waste out, get carbon dioxide in, get oxygen in, and get carbon dioxide out. And that's going to happen much more efficiently if the cartilage can kind of squeeze in and squeeze out some of the synovial fluid, kind of like a sponge a little bit. And that's what happens when we move our joints. It keeps that articular cartilage nourished and healthy. All joints have a rich blood supply, particularly synovial joints. The more movable the joint, typically the more blood vessels and branching blood vessels that you find surrounding that joint. If you think about, if you completely bend your elbows as much as possible, then you're definitely pinching some arteries and veins there. Well, we've got a lot of different pathways around the elbow, so I don't have to worry about, cutting off the blood supply to my hand, for example, when my elbow is in a bent position. So we can continuously flow around these joints. The networks of blood vessels that surround any part of your body, give alternate pathways to get somewhere, are referred to as anastomoses. I also oftentimes think of these as kind of like the freeway system we have here in Southern California. From Irvine, there are a lot of different pathways you could take to get to, say, like downtown Los Angeles. If there's a clog on one freeway, some big accident, then, your mapping program will tell you, get off here and take this other road and hop on this other freeway and get up there. So, you could take a straight shot all the way up I-5, or you might take the 405 and cut up on the 110. There's a lot of different options to get to downtown Los Angeles from Irvine. That's like the anastomoses, right? If there's a block somewhere in one blood vessel, well, the blood can just flow through a different artery and get around and get to its final destination. So that is a constant theme that you'll see that we'll see again in the cardiovascular system. And then finally, joints. These synovial joints are always going to be richly supplied with sensory nerves. Sensory nerves are there to detect pain, so this is what makes joint damage so particularly painful. But sensory nerves, most of them are there to actually monitor stretch in the joint capsule. This is how we can know to bend or straighten a joint to a particular position. If I wanted to, let's say, carry a dinner plate from the kitchen to my dining room, I want to make sure that I hold that plate flat so that the food doesn't slide off of it. Well, I need to make sure that my elbows are bent to a particular position and that my wrists are in a particular position and that my shoulders remain in a particular position. And I can do all of that without having to look, right? The reason I can do all of that without looking at all my joints is because I've got these sensory neurons that are sending signals to my brain to provide information about the positioning of all of those joint capsules, how much they're being stretched. And that tells me that my elbows are at a 90-degree angle, for example. And this is something that we learn over time. You know, if I ask my kids to do the same thing, I have to constantly remind them, hold your plate straight, hold your plate flat. You know, otherwise I end up with spaghetti on the floor. It makes the dog happy, but nobody else really. So, you know, what they have to do is look down at their wrists and make sure that they're holding their plate flat. The more you do something, the more you practice something, the more your nervous system learns. And by learning, I mean that your nervous system, really your brain, recognizes what kind of stretch is associated, which sensory receptors are associated with a 90-degree angle, right? Holding that plate flat. And eventually over time, you can do that without even having to pay attention to it anymore. So that is the whole reason why we have such extensive innervation of our joints, so that we can gauge exactly how much bend or straightening that we need to provide, how much movement in the joint to achieve a particular job or function. So we classify synovial joints just like we had subclassifications of cartilaginous joints and subclassifications of fibrous joints. Remember, fibrous joints, we had our sutures, we had our syndesmoses, and we had our gomphoses. For the cartilaginous joints, they could either be a synchondrosis joint or a symphysis joint. Well, synovial joints are not all the same either. We classify these guys by the shape of the articulating surface. It turns out that the shape of the two bones that are articulating are going to mostly influence the degree of motion, the type of motion that's allowed. So remember, all of these joints are classified as diarthrotic. This joint here is described as a plane joint. It's a synovial joint. There's a fluid-filled cavity surrounding the articulating surfaces here, but the two articulating surfaces are flat planes, and they allow for a short kind of gliding motion, side to side and back and forth. So it is considered biaxial. Moving side to side and back and forth gives us two different directions of motion, but they're short, they're small gliding motions. One example is the joint between two of your carpals. These are the little rock-like bones in your wrist, and they allow for some slight motion. You can kind of move your wrists anterior, posterior, and lateral and medial. The main mover of your wrist joint is back here, but these carpals can join or can slightly move adjacent to one another when you're bending and straightening your wrists or moving your wrists from side to side. These gliding motions do not involve any rotation or any twisting motion. It's just the short gliding motion of side to side and back and forth. The next one is a hinge joint. In a hinge joint, we have a cylinder-shaped end of one bone fitting into a trough, kind of like a cup shape of another bone. An example of this is the trochlea of the humerus fitting into the trochlear notch of the ulna. This is located at your elbow. Hinge joints are only going to allow movement in one plane. It's described as uniaxial movement. The elbow, if you move your elbow, it's just designed to bend and straighten. That's it. An anterior, posterior motion. There's no side to side. There's no twisting or rotation movement. It's just movement in one plane, this uniaxial movement at this hinge joint. Your knee is considered hinge joint. The joints between your phalanges, so your two distal knuckles that you have on digits 2, 3, 4, and 5 are all considered hinge joints as well. Again, just those distal knuckles, the interphalangeal joints. The pivot joint is up next. So a pivot joint only allows for twisting or rotation movement, we call it. This pivot joint, the example we're looking at here, is the rounded end of the radius, kind of looks like a radial tire, right? That's where the name comes from. Radius, radial, circular. And then it fits right here into the radial notch of the ulna. Now there's a ligament that wraps around that round head of the radius and holds it in place against the radial notch of the ulna. So the only movement that's allowed here is for the radius to rotate. It can twist within that kind of encircled ligament here. So that is our pivot joint. Another example of a pivot joint is the joint between C1 and C2. The dens of the axis sticks up into the vertebral foramen of the atlas, and there is a ligament that wraps around that dens and allows us to pivot the atlas side to side. We get rotational movement while the axis stays stationary. That movement is what allows us to turn our head side to side, kind of shake your head no. That is the joint between atlas and axis is a pivot joint. Next up is a condylar joint. This is when we have the egg-shaped, kind of an oval shaped articular surface of one bone fitting into an oval convex surface of another bone. So we have both concave and convex surfaces fitting together. The knuckles that are located at the proximal end of each finger. So this is referred to as your metacarpal phalangeal joint. The metacarpal 2 is articulating with proximal phalanx 2 right here. That is your metacarpal phalangeal joint for digit 2, digit 3, digit 4, digit 5. These are all considered condylar joints. You might have an older textbook. They used to be called condyloid joints. So it depends on which textbook you're using. Our textbook calls it condylar joints. The movement here is biaxial. We can move these bones side to side and back and forth. So again, if you're looking at your fingers, try to keep the actual interphalangeal joint straight. And what you can do at this joint here between the metacarpal and the proximal phalanx is bend and straighten your digits and then spread your digits apart and pull them back together. So that's, again, the metacarpal phalangeal joints for digits 2 through 5 are all considered condylar joints. No rotation, no pivoting or rotating around an axis is allowed for those joints. Next up is a saddle joint. Saddle joints are hard to describe without using the word saddle. To me, this looks like a horseback rider, right, sitting on a saddle. The official textbook definition describes each articulating surface as having both concave and convex surfaces. So you want to think about that. The saddle joint, the example given here, is located between the first metacarpal and the carpal just located beneath it, called the trapezium. The first metacarpal and trapezium bone are going to articulate at what we might call the ball of your thumb, the base of your thumb. So this is going to be your joint of your thumb's metacarpal 1. So we're looking all the way down, almost at the wrist here is where this joint is located. If you are maybe like typing on a keyboard, it's this part of the palm of your hand that might be resting on the surface. That's how far proximal we are in the hand here. So if we take a look at that ball of the thumb, right, this is saddle joint, and it does allow for this side-to-side movement and the back and forth movement, but a greater degree than the condylar joints. Right? You can't really, most of us, cannot bend our fingers down just using that condylar joint between the metacarpal and the proximal phalanx to bend our fingers down to touch our wrist or to touch down pretty far. But what you can do with your thumb is stretch your thumb almost all the way across and can touch the palm of your hand. And certainly your thumb can touch all four tips of all four other digits. And that is due to the degree of motion, the greater degree of motion that's allowed by this saddle joint. So it's still the same back and forth, side to side, but to a greater degree because of the saddle joint. And then finally, the most freely movable joints in your body give us multi-axial movement. And the example that we have here is a ball and socket synovial joint. Ball and socket joints are when a rounded, ball-shaped end of one bone fits into a concave, rounded socket of another bone. A ball and socket joint exists at your shoulder. It's the joint between the head of the humerus and the glenoid cavity of the scapula. We also have a ball and socket joint at our hip. The rounded head of the femur fits into this deep socket in your pelvic girdle, your coxal bone. That socket there is called the acetabulum. So we get this nice deep socket that fits at the hip. Multi-axial movement allows for back and forth movement, side to side movement, and rotation, twisting movement at these multi-axial ball and socket joints. So shoulder and hip are your examples of ball and socket.